Namaskar, good morning. Myself, Dr. VIPUL GURJAR. I'm the professor and head of the department in Sumandip University, Vadodara. Today is December 2024. Today I want to share my own fistula surgery complication, and during this uh, uh, treatment of this complication, I learned a small lesson from it. So I want to share with you. It may or may not be helpful to you, but I think some anatomical and physiological consideration must take during the fistula surgery. This is a message from this case discussion. I have a two case which were operated on the same day. My practice, if it is a small track and straight track, I am not doing the MRI in each every case, but whenever there is a curved fistula or long track or multiple opening, and I am not able to find out the internal opening clinically, then I definitely recommended the MRI fistula. In this case, one patient having a MRI and second patient having a anterior track, external opening having a just below the base of the scrotum, and internal opening I felt at a 12 o'clock position. So I didn't do the MRI report. Now where are the internal opening in both the case? In the first case, where there is a 3 o'clock external opening 6 centimeter to 5 to 6 centimeter distal to the anal verge at 9 o'clock position, and there was a curved fistula which were opening 2 to 3 centimeter inside the anal canal. That means it is just proximal to the sphincter, internal sphincter. Okay. While in a second case, the external opening was just below the base, and same thing, this internal opening felt just 2 to 3 centimeter, 2 to 3 centimeter proximal to the anal verge. So we did under spinal anesthesia. I did methylene blue test, and I started the coring of the fistula. With a good assistant, I were able to excise both the case whole fistula tract with its branch up to the internal opening. So everyone clap. Very good. This is such a beautiful surgery, neat and clean surgery. My resident, my APs all admire. Very good, superb dissection. I also glad myself that I have done a very good job up to the internal opening. So then I close the internal opening, then I close the sphincter fiber what I have cut, and in a 2 or 3 layer I have closed the this defect. So I was very much confident about my result. But as you know, all the sutures are giving away after 6 to 7 days. So among one patient was remained admitted in this general hospital, and he doesn't want to go house. While another patient, after passing a stool on fourth or fifth day, he went to his home. So the patient who remained inside the hospital on 6th or 7th day, we found a fecal discharge from the wound. So on examination, definitely there was a defect found at the near the internal opening where I have closed. So we took this patient further in the operation theater and examination that internal opening suture gave away. Now further, because I want to save that sphincter mass, I don't want to cut that sphincter mass, and because of the is a middle age and I don't want to put in a incontinence phase. That's why I further resuture and give the drainage with the Foley's bulb in the cavity with the pressure also, and came out further. On sixth or seventh day, the patient who went to home, he also come back with the same problem, fecal discharge from the wound. Though he has passed daily motion in initial days, 4 to 5 days, there was no problem. But on sixth and seventh day, this giveaway of internal opening suture. So I took both the patient inside the further in a operation theater, and then I examined the same manners that the internal opening was suture, though it was very much accurately taken with the PDS 20 with good bite, not the superficial, with the good bite, though it was given away. Why? Now the lesson is why. See, this is the anal verge and it is surrounded by the sphincter complex. Okay, now, this opening is just proximal to the anal verge, that is near the about the some sphincter complex. So I have sutured this sphincter complex. Now what happens in a routine practice? This anal verge is a high pressure zone. It is a watertight. God has gifted this. This is a what should be a watertight. Flatters is also it's voluntary, not the involuntary control. Okay, so all the sphincter complex is made for the watertight leakage. Okay, now so that's why it is a high pressure zone. So whenever there is a passing of stool and this internal opening suturing is the human made Wiccan wall. This means we have cutted and further sutured. That's why it is a human made Wiccan part. Because of this sphincter high pressure zone, this internal opening gave away, and that create a further recurrence of the fecal contamination in the wound. So now this time I have cutted the sphincter or distal part of the sphincter and then close the partial distal part, but this some part of the sphincter or the 30 to 40 50 70 percentage sphincters I have cut it. Now the patient is feeling well, there is a no contamination or there is a no incontinence also, as well as the wound is healing. So in this way the lift technique is come in mind why they have not excised the internal opening, why they are doing ligation in between the sphincter fiber. So this is a theory and I felt this is happening to us also. So in my view, 2 to 3 things we have to do. If you are doing the proximal excision, that means including the internal opening and removal of internal sphincter fiber with anocryptal gland excision, then ligation of the trach, then dealing of external distal part of the fistula, either laser or scraping or the coring, whatever you feel is the first, or it may be your choice. It must be your choice. Second thing, you may do the lift technique and do the excision or laser ablation of distal trach. It's your choice. But whenever there is a high internal opening, only coring and closing of internal opening with the sphincter mass may create a problem because of the distal high pressure zone sphincter complex. We have to cut it. Okay, so I think this is the message I want to convey.